Good afternoon, ladies and gentlemen. I'm Dr. Meiyun Wang from Henan Provincial People's Hospital in Zhengzhou, China. It's my great honor to speak here. My topic is HIFU in brain therapy, general concept and applications to ET and PD treatment. I have nothing to disclose regarding to this talk. In this talk, I'd like to introduce the general concept of HIFU, MR-guided focused ultrasound applications in PD and ET, and the progress of MRgFUS. Firstly, let's start with the general concept. High-intensity focused ultrasound, or short for HIFU, utilize focused or high-intensity ultrasound waves to achieve some application of targeted tissues. Up to now, HIFU has been applied in the treatment of uterine fibrosis, prostate cancer, liver cancer, pancreatic cancer, breast cancer, bone tumors, and so on. However, its application in the brain remains challenging due to the lack of precise guidance. Magnetic resonance guided focused ultrasound, or short for MRgFUS, with real-time MR guidance, enables precise treatment of brain disorders such as Parkinson's disease and essential tremor. MRgFUS combines the advantages of MRI and ultrasound. MRI can provide high-resolution soft tissue and real-time temperature monitoring during treatment. Meanwhile, ultrasound offers a non-invasive treatment approach. Moreover, MRgFUS does not require general anesthesia, allowing for real-time feedback during treatment. High-intensity MRgFUS thermal ablation has demonstrated efficacy in treating PD, ET, obsessive-compulsive disorder, and neuropathic pain. Low-intensity MRgFUS has greater potential in blood-brain barrier opening for drug delivery and neuromodulation. Next, I'd like to introduce MRgFUS applications in PD and ET. In 2018, the US FDA approved MRgFUS treatment for Parkinson's disease with tremor. On February 28, 2019, our team successfully performed the first MRgFUS treatment for Parkinson's disease with tremor in mainland China. This map is from an article published in Nature Review Neurology in 2021. It illustrates the global landscape of human-focused ultrasound clinical trials. The figure shows the trials that are registered and active at clinicaltrials.gov, spanning diverse neurological indications and biological mechanisms. Our hospital is located in Zhengzhou, shown here on the map. Parkinson's disease, or short for PD, is a common neurodegenerative disease. Drug treatment may work well in the early stages of PD, but many patients develop drug-resistant symptoms as the disease progresses. Deep brain stimulation therapy has limitations, including invasive electrode implantation in the brain, high cost, and demanding maintenance requirements. Here is the information of the first PD patient we treated, a 52-year-old woman who suffered from the right upper limb tremor for more than 5 years. Initially, the tremor was mild and responded well to medication. However, as the disease progressed, the medication became less effective, and the high drug dosage led to intolerable side effects before she came to our hospital for medical care. This video shows the treatment procedure for this patient. From this video, we can quickly observe that the patient tremor was stopped in the MRgFUS. From these two videos, we can see that before treatment, the patient struggled to drink with spilling, and after treatment, she was able to drink water normally. Also, before treatment, this patient had difficulty in pouring water. After treatment, she could pour water with significantly improved control and precision. Here are assessments of the patient's writing ability. We can see that prior to treatment, the tremors severely impaired the legible writing. After treatment, the handwriting demonstrated significantly improved clarity and motor control. This video shows before treatment, the tremor made it challenging to draw smooth shapes. However, after treatment, the patient achieved significantly improved accuracy in shape drawing. And the patient was very happy and expressed gratitude to our clinical team. This case demonstrated the profound impact of MRgFUS treatment on patient quality of life. Ultra-intermediate nucleus or short for WIM is the most common target in MRgFUS treatment for Parkinson's disease, which mainly improves the tremor symptom. For tremor-dominant PD patients, MRgFUS treatment for unilateral WIM is a safe and effective method. 3 months after treatment, non-medication median tremor scores were improved 62% after MRgFUS ceremotomy and 22% after sham procedures. Thus, the treatment results proved that MRgFUS ceremotomy group was significantly better than those in the sham group. For early-stage tremor-dominant PD, MRgFUS ceremotomy for unilateral WIM not only improved the tremor symptom, but also reduced the need for dopaminergic medications. At 6 months follow-up, the reduction in motor score was significantly higher in the MRgFUS treatment group than the medication treatment group. Notably, while the daily levodopa equivalent dose was significantly increased in the drug treatment group, it remained decreased or stable in the MRgFUS treatment group. Other targets can also be used for MRgFUS treatment of PD. For instance, globus pallidus treatment mainly improves rigidity and bradykinesia symptoms. MRgFUS unilateral globus pallidus internus ablation resulted in a higher percentage of patients with improved motor function or reduced dyskinesia than a sham procedure. At 3 months after treatment, 77% of patients in the MRgFUS treatment group had a response. At 12 months after treatment, 70% of patients continued to exhibit a response. Diffusion tissue imaging, or short for DTI, can track fibers in the brain, which may provide important information for target localization and treatment efficacy evaluation. We can see that the high angular resolution diffusion imaging constrained spherical deconvolution-based tractography allows identification of direct connection between the cortex and the external and internal segments of globus pallidus. Pallidothalamic tractotomy, or short for PTT, is also an effective target for MRgFUS treatment of PD, which mainly improves the rigidity and bradykinesia symptoms. The MRgFUS PTT treatment achieves similar efficacy with less risk and more precision than radiofrequency. At 2 days after treatment, the ablation areas had different manifestation on different images. At 3 months after treatment, the case in the first line demonstrated no ablation lesion on titulated image. The ablation area could be seen only in the case in the second line. Subthalamic nucleus, short for ST treatment, is also an option for PD patients. It mainly improves the rigidity symptoms. At 4 months after treatment, the motor scores were improved by 52.6% and 4.2% for MRgFUS ST treatment and sham treatment, respectively. For 90% of patients, the MRgFUS ST treatment improvement could last for 3 years. The improvements in motor symptoms were associated with increased grammatical density in cerebral regions, as well as reduced fractional amplitude or low frequency fluctuation activity in the frontal, temporal, paracentral, and posterior cingulate corticals. WIM as a target can improve tremor but does not resolve rigidity and bradykinesia. PTT as a target can improve rigidity and bradykinesia but does not resolve posterior motor tremor. Therefore, MRgFUS treatments with dual targets including WIM and PTT can simultaneously improve tremor as well as rigidity and bradykinesia symptoms in PD patients. Essential tremor, or short for ET, is a common movement disorder characterized primarily by postural tremor and kinetic tremor. MRgFUS is also a safe and effective treatment method for ET patients. This is a 45-year-old ET patient who had suffered from tremors for 30 years. He had mild tremor at the initial presentation, with progressive worsening over time, but the drug treatment had poor effectiveness. From the video, we can see that the patient's finger movements could not reach stability before treatment, but returned normal after treatment. And before treatment, the patient had a problem with cup pouring tasks. But after treatment, pouring water movements showed markedly improved stability. And also before treatment, he suffered from the impaired chopstick manipulation. After treatment, the chopstick handling was significantly improved when eating. And this video shows a significant improvement in drawing performance before and after the treatment. MRgFUS treatment targeting the WIM can significantly improve the tremor symptoms in ET patients. The T2-weighted images demonstrate a progressive ablation lesion volume reduction throughout the 3 months post-operative follow-up. MRgFUS WIM treatment can ameliorate tremor in ET patients by modulating the brain networks. Pre-MRgFUS patients showed a significant decrease in functional connectivity compared with healthy controls in SMN and VSN. Post-MRgFUS ET patients had a significant increase in functional connectivity compared with pre-MRgFUS patients in both SMN and VSN. Previous studies observed the adverse event profile of MRgFUS treatment in patients with PD and ET. The reported adverse effects were mild in severity, with a progressive decline in incidence over time. Next, I'd like to talk about MRgFUS research in our group. Our team explored the effect of MRgFUS on the brain functional network in PD and ET patients, and the findings were published in MPG Parkinson disease. The resting state functional MRI was performed on PD and ET patients before and 1 month after treatment, as well as on healthy controls. We analyzed the changes in brain function after MRgFUS treatment and their correlations with critical scales. The clinical rating scale for tremor score of treated site was significantly decreased. Some brain functional networks were significantly changed after treatment. The sensory motor network showed the widest range of changes. We found that the similarity of cerebellar cortex functional connectivity in patients with tremor increased from 0.69 to 0.84. The motor cortex network tended to normalize after treatment. In addition, there was a significant positive correlation between the changes of cerebellar cortex functional connectivity and the improvement of clinical tremor rating scale. Thus, the recovery of brain network may be one important reason for symptom improvement. Usually, it's hard to localize the WIM on conventional MRI images. Currently, WIM is indirectly localized using the anterior commissure, posterior commissure, or short for ACPT reference line. However, this approach has limitations such as time-consuming and poor accuracy. Our team has developed a direct WIM localization method based on quantitative susceptibility mapping. This novel method has been granted an invention patent in China. Direct visualization and localization of the WIM based on quantitative susceptibility mapping are promising methods to get MRgFUS treatment. Next, I'd like to move to the progress of MRgFUS, mainly focus on low-intensity MRgFUS in BBB opening and neuromodulation. Low-intensity MRgFUS combined with intravenous injection of microbubbles can safely and reversibly open the blood-brain barrier. Low-intensity focused ultrasound promotes the expansion and contraction of the microbubbles, which increase the space between vascular endothelial cells, resulting in the BBB opening. Therapeutic agents can diffuse across the disrupted BBB to enhance the effectiveness. In a non-human primate model of Parkinson's disease, low-intensity MRgFUS successfully opened the BBB in PD-associated brain regions such as the premotor cortex, posterior ventrolateral thalamic region. For PD patients, MRgFUS with microbubbles also can open the BBB in parietal, occipital, and temporal lobes. After BBB opening, gadolinium contrast enhanced T1 weighted image showed a significant enhancement in the BBB open areas. These enhancements disappeared after 24 hours, indicating that the BBB could reversibly close within 24 hours. Adeno-associated virus 2 can load silent inflammation regulator 3 for the gene therapy. The immunofluorescence of red brain tissues shows that the gene drug 33 was expressed in the BBB opening area, but was not expressed in the contralateral area. Thus, MRgFUS combined with microbubbles is able to temporarily open the BBB to achieve drug delivery. This study used MRgFUS to repeatedly open BBB in PD patients, which enabled the beta-glucocerebral settings drug treatment. The butamino PD patients were treated once every 2 weeks for 3 consecutive treatments. MRgFUS BBB opening is expected to improve the efficacy of drug treatment. In this study, PET-MR was also used to assess the MRgFUS BBB opening in the monkey and PD patient respectively. Both gadolinium-enhanced T1-weighted image and fluorescein choline PET could effectively display the BBB opening areas. At present, animal experiments show the expression of inflammatory factors and activation of microglia and astrocytes in the BBB opening area, which indicates the existence of stereo inflammation. Therefore, in future clinical work, it is necessary to explore safer bounds and strengths and consider the benefit-risk ratio for patients. Low-intensity focused ultrasound can also be used for non-invasive neuromodulation, which achieves effective neuromodulation treatment in PD animal models. Using low-intensity focused ultrasound to stimulate the motor cortex or subthalamic nucleus of PD mice alleviated motor symptoms and had a neuroprotective effect on dopaminergic neurons. In addition, it can significantly reduce PD-related neuroelectric activity in the motor cortex of PD mice. MRgFUS neuromodulation can change the GABA levels in specific brain areas of healthy volunteers. After low-intensity MRgFUS stimulation, GABA levels in the posterior cingulate cortex were reduced and could persist for at least 15 minutes. There were no significant changes in GABA in the DACC, indicating that MRgFUS neuromodulation effects might be related to the location of the brain region. In summary, non-invasive treatment is a trend in medicine. Non-invasive MRgFUS provides more treatment options for patients and is expected to treat more disease in the future. Thank you very much.